is to create a community of practice for supervisors in behavioral health in New Mexico. This is a forum for discussion about best practices in supervision based on the state of New Mexico's clinical supervision implementation guide. Please remember to turn and keep on your cameras if possible. Our agenda is simple. We begin with a lecture followed by a case presentation, an issue related to supervision in behavioral health submitted by one of our participants. After the hour-long session, participants are welcome to stay for another 10 or so minutes after the echo to ask any more questions, share about their work, and learn more about the work of colleagues in the group. First, I'd like to spend no more than 3 minutes with brief introductions. I'm going to start with our technical support, Reina.
Good afternoon, everyone. Reina Torres, Program Coordinator, and we'll be joining you all new for clinical supervision. So if you do need any assistance with your audio, visual, please reach out to me, and I will be also providing assistance for our CEs and evaluations. So I'm happy to be here with you all.
Thanks, Reina. Denise.
Hi, everyone. My name is Denise Moore. I'm the clinical director at Terra Nova Counseling Center of Southwestern College in Santa Fe, and I am a hub member with this ECHO.
Sonia.
Everybody, my name is Sonia Briones, and I am supervisor at Allface in the Placement Services Department. It's good to see everybody, and I will pass it to Lacey.
Actually, I'm going to introduce Lacey. So, because she's one of our presenters. Brenda.
Thank you, Jen. Hi, everyone. Buenas tardes. I'm Brenda Quiñones Cortez. I lead El Puente de Encuentros, a nonprofit that supports students of color entering the mental and behavioral health field, and I'm excited to be part of this hub. I will pass it over to, oh, sorry.
That's okay. Natalie.
Hi all, my name is Natalie. I am a licensed clinical psychologist and postdoctoral fellow and one of the hub team members here.
And we have a couple of hub team members presenting who I'll introduce in a moment, and we've got a couple of hub team members who are out today, Olivia and Michelle. And if you'd like to introduce yourself, as an attendee, feel free to do that in the chat. So let me introduce our two presenters today, and then I will pass it over to them. So Lacey Keith is a proud alumni of Eastern New Mexico University, graduating with a bachelor's degree in psychology and sociology in 2002 and master's degree in counseling in 2012. In March of 2025, Lacey earned her master's of healthcare management from Colorado Technical University. She has been working in the mental health field and with Mental Health Resources, Inc. since 2007. Lacey has provided clinical and paraprofessional supervision as a clinical director of New Mexico Mental Health Resources since 2016. Lacey's mission as CEO is to encourage and to ensure access of quality care, provide a safe space for growth for both her clients and staff, and be a beacon of hope in the community. And John Berkey is our second presenter. He holds an MA in counseling from Eastern New Mexico University, a licensed professional clinical counselor, LPCC, with supervisor designation. He has been a therapist since 2018. He currently works at Mental Health Resources as a clinical supervisor and teaches master's level counseling courses at ENMU. John has lived in Clovis since 2002 with his wife of over 41 years. He enjoys yard work, sci-fi movies, Netflix binges, and spending time with his family. He is currently working at Mental Health Resources as a clinical director with CareLink, New Mexico. He also works as an adjunct professor at ENMU teaching master's level counseling. So at that, I will turn it over to Lacey and John to present their didactic.
Thank you, Jen. Let me share our presentation.
Okay. So I'll go over all the necessary pieces before we jump in. So John and I do not have any kind of financial arrangement in relation to the content of this activity. And the views that are expressed here are those of John and myself and do not necessarily reflect or represent the views and policies of the University of New Mexico. This hour of education and didactic engagement is eligible for CEU credits. At the end, we will have a QR code that you can scan and complete the survey for that. You must be present for the entire time. You have to complete it within 48 hours, and your certificates are then automatically generated or emailed to you. So that's all the necessary things. All right. So John is going to be our main presenter today. I'll chime in here and there, but our topic for the day is supervision in an integrated care setting and navigating supervision within an interdisciplinary team. John, you just let me know when you're ready for me to change slides.
Okay, objectives describe how to supervise multiple behavioral health providers with different scopes of work. Explain the importance of supervision in an integrated care setting, and describe how supervision in an integrated care setting improves client outcomes. Okay. The challenges in an integrated team. I think one of the big ones is probably role ambiguity. Sometimes you get into a situation or you get with a member, teams do not fully understand each other's professional roles and responsibilities, can lead to overlap or tasks being dropped. Then the dropped one is probably the most concerning. But then when you also get with the doubles, okay, who's going to pick this one up and who's going to go with it? That is why the second one is communication barriers. Difference in technologies, acronyms, communication styles across disciplines, inconsistent documentation, or lack of shared systems. With here at MHR, we pretty much share the EHR, employee health record, or not employee health record, electronic health record. So we can see what the counselors are doing. We can see what peer supports are doing. We can see what care coordinators are doing. So we still have some communication issues sometimes, in that maybe the notes are not clear, maybe something kind of got left out. One of the big advantages to the communication, or why there's a big need for communication, I feel, is that members, clients, whatever your organization chooses to call them, will tell the counselor one thing, they will tell their care coordinator one thing, they will tell their peer support something different. So there's a lot of, I don't want to call it triangulation, but that's what it kind of seems to come out as. Power dynamics and hierarchies. I think that one's, medical professionals may perceive as having more authority than behavioral health or social services. Sometimes it can be kind of a contest. Time and workflow constraints is a big challenge. When you've got a couple of members on the care team that you need to get together, that's kind of one thing. But when you start trying to get their therapist, maybe the nurse, care coordinators, peer supports, CCSS, whatever they may have in one meeting, schedules kind of get to be a problem. We kind of solved that to a degree with, we have a monthly meeting, CareLink does, with outpatient services to go over members that we share. And again, going over, this member has shared with us this, it's a concern, this, whether they tell their therapist, whether they tell their care coordinator. So it does help. Accountability and supervision confusion. Again, it goes back to, I believe, knowing what the other team or team members do, what their role is, and that sort of thing. Supervision bias towards own discipline. Yes, we at CareLink are the boss, or we in outpatient are the boss, or I'm the doctor. I've got a PhD and an MD, and I'm the smartest person in the room. So sometimes things like that can happen. Okay.
So yeah, and just to add on, to what John is saying, we have lived and experienced all of this in our setting, as having, I think we've got 10 or 11 different programs open, and running. And most of our clients can be engaged in multiple of those programs at any given time. But John and I are a perfect example of how difficult communication can be. He and I work a mile apart. We work a mile apart, and we could not for the life of us find a time to sit down and work on the slides together. So we've been sending instant messages back and forth. Hey, what are you doing here? Hey, what are you, so it's, when you're talking about then getting care team members together and possibly bringing the client in, there are so many barriers that you can reach on this. So. All right.
Yeah, yes, that is a perfect example. And I'm even wondering, if we worked in the same building, would it be really any better? It's just carving out time. And it is important that we do that, but we get busy. We get busy with our own rat killing, and it'll wait. Okay. Oh, okay. Never mind. You did go to the next slide. Holistic patient care. Okay. Opportunities in interdisciplinary teams. You get input from multiple team members, whether it be the doctors, the nurses, counselors, their primary care physicians, whoever is on their team, and you get that, okay, here's what I'm seeing, okay, here's what I'm seeing, and how can we work together to solve some of the issues that this client is having. Shared learning and professional growth kind of goes along with that. The more I know about RAP, for instance, the more I understand how RAP can help our members. And the same way with you can pick any of the divisions we got. And do we know everything about all of them? I can certainly tell you I don't. It improves patient outcomes. In other words, the more we can work together, the better off the client is going to be, the member, and the more help they're going to be able to obtain through this varying chorus of professionals. And each one is going to have a little something different to bring to the table. But it's also important not to dismiss those. Well, we don't do that. We've never done it that way. I think that's a big thing with lots of organizations. Stronger team cohesion and morale. The more we get together with the therapist, with IOP, the other programs and the better relationship we have with them, the more able we are to get together and be that cohesive team. It's kind of hard to be on a team with people you may or may not know very well or at all. Innovation and care delivery. You know, you've got 6 or 8 people on a care team. You're going to get different ideas. And as the other care teams looking at that, we need to be open to those ideas. We may not be our idea. It may not look like what we are used to, but that's okay. Change is more often than not very good. Enhanced system efficiency. I think it kind of got brought up on the last one. I think somebody mentioned the MAT program. So if we have a member client who is in the MAT program, which is primarily just drugs for substance abuse, why are we not going to connect them also with IOP, which is the drug counseling, drug and alcohol counseling, or where they get, group counseling, they get some individual counseling, or can we send them also to just a regular therapist for just individual counseling? Because I think the medications I think are valid and helpful. Is that really the only bullet we have, so to speak? So it enhances how well we are working for the client and with the client. Okay. Tools and strategy for effective supervision. Team charters and role clarity maps. That kind of goes back to what I mentioned before about ambiguity. Do the peer supports with CareLink work a little bit differently than the peer supports out of the outpatient side? It's not a big difference, but there is some differences. Regular interdisciplinary case reviews. In other words, getting together with your teams, getting together with, like I said, we have a monthly meeting with outpatient to go over shared clients, things the therapists are seeing, things the care coordinators are seeing. In the future, that may be expanded to kind of everybody. I don't know. Reflective practice groups. That one, looking back on what we're doing and seeing how do we improve what we're doing? How do we improve patient care for not just for the individuals, but as a whole? Conflict resolution protocols.
John, can I jump in on that one?
Yes, you may.
Sure. So the reflective practice groups, I think, is also a good space. When you're working with clients that are involved in multiple systems, even within your agency, we're often talking about, our high risk clients, folks who have, lots of comorbidities, things that need to be addressed in, immediate fashion. And that means we can also have lots of critical incidents that happen. Right, so those reflective practice groups are a chance to be able to sit down with any particular critical incident that has occurred, and as a team to say, okay, was there something missing in the front end as far as communication goes? Was there something missing from the safety and stability plan that needs to be added in? Or now that we know that this is a potential issue with this individual and, substance use or medical issue or whatever, how do we build then a safety net around them? So you can use that reflective, time with your team to say, okay, how do we take and learn from this and then move it forward into our next, care venues. So.
Okay. conflict resolution. You get more than 2 or 3 people together and one's got one idea, one's got the other, you know, are we just gonna put on our boxing gloves and figure out whoever's standing wins the argument, has the better idea? No, we really don't want to do that. And that kind of goes back to knowing your teams, knowing what the different members of the team, of the care teams, do, what their scope of practice is, and just knowing them as people can help alleviate a lot of that. And then when you do, you have kind of some written rules. If we have a big differing of opinion, how do we settle it? Feedback loops and 360 reviews. I see that as having outpatient maybe review some of the things we do in CareLink. Now, do they know everything that we do? Maybe, maybe not. But what they review and see as issues may just be simply they don't understand. And it's the same with us and any of the other programs. You know, sometimes we think, oh, they can take care of that. They should be taking care of that. Well, maybe we should, but maybe it's not really in our wheelhouse. So feedback from other departments, I think, is going to be important. Okay. Best practices: establish supervision contracts and agreements early. What I take that to mean is you have, for lack of a better word, agreements with, say, other supervisors and other programs. You have issues, they come to me, they come to one of our other admin supervisors, and we talk it out, kind of try to find a resolution. Normalize interpersonal learning. And I still think that goes back to knowing what the other departments do, how they do it, and what their scope of practice is. And again, I don't know, there's a lot of people, are we going to hang out and go to barbecues and stuff together? Yeah, maybe, maybe not. But we do need to normalize those relationships with other departments, because then we're not afraid to go to them.
And I would also say, in conjunction with that, is when you can learn to speak the speak of the other programs, then you can more effectively communicate what needs to happen.
Yes. Communication, I think, is a big part of all of this, because you have to talk to each other. You have to figure out what's going on. Sometimes what they're telling one department that they're not telling the other, and sometimes getting to what the real truth is. Lead with curiosity, not control. Again, it goes back to learning what the other departments do within your organization, even departments outside of your organization. If you're talking about a inpatient facility, what do we know about them? For us right now, they don't really talk to us much. And that is kind of unfortunate. But leading with curiosity instead of control and or judgment. Co-create metrics of success, not just productivity. And I think the big deal there is co-creating the metrics. I was told something here, been years ago, that I have used with clients a lot, is if they come up with the plan, they are much more likely to follow through with it than if I give them the plan and say, here's what you need to do. They're much more likely to follow through. And I think with communication within the departments, I think that can be said as well. Come to an agreement, a little give and take, a little compromise, and we're looking for success, not just numbers. Numbers are easy to look at. They're also sometimes kind of easy to manipulate. Enough said about that. Regularly revisit team norms and goals. I think that kind of goes back to what the 360 review thing. Are we keeping up with goals for our members? Are we changing those goals as they progress or as they decline? Are we revisiting those goals? Because if you don't have the goals, you don't know where you're going. And you're very, very likely to get far, far off track. And again, if everybody is working towards the same goal, it's much easier for us to say, what are we doing to help with this member's goals? You know, their goal is sobriety. What are we doing in our goals as a department to enable that outcome? Okay.
Here's the resources that you can tap into. If you go and search supervision within interdisciplinary teams, integrated health models, there's a lot of information out there. There's more than one way to get to an integrated care model, and there's more than one way to get to the supervision piece within that. But the best practices that John just discussed are going to be your key aspects there, right? Communicate, be intentional with it, and make sure that you're leading from what the client is wanting and needing, versus what we as the professionals think maybe need to have occur in their life. So, all right. And
Well, thank you.
Jen, I think the slides did go out with the introduction, or can they be shared again with participants?
I'm seeing Natalie shaking her head. Yes. So it's, yeah.
Okay. I'm going to I'm going to stop sharing. Hold on. And then I'll bring this back up at the end of our thing. Okay. Kind of break. It's just, it's a doctor talking to a paraprofessional versus, this is Dr. So-and-so talking to, to Janet, who they are very familiar with and know how they interact with the client. So there's a lot of power in just the familiarity of peers and team members.
Thanks.
Any additional questions before we move into the case? Okay.